So I'm excited to bring you Dr. Greg Pontone today. He's a really cool psychiatrist who totally, I think, drinks the same Kool-Aid that I do. And I've been on a journey to find a psychiatrist who understands sort of the wellness and sort of the mind-body connection and some of the things that I've been exploring, and really thinks about the patient-centered approach and sort of how we can think about things a little outside the box to bring, a better sort of quality of life and a better way to live for our patients with Parkinson's. So Greg joins us. He's a psychiatrist, a geriatric psychiatrist who's trained largely at Johns Hopkins. He's originally from Detroit, and he is there doing some great work. Actually spends a lot of time even on the inpatient unit, believe it or not, on the geriatric psychiatry ward. So really knows the sort of breadth of inpatient and outpatient psychiatry, and I think is just a really different sort of open-minded approach to things around mind-body approaches, mental health in Parkinson's, and sort of thinking about the approach that we have in a different way. So I gave Greg some pep talk to think a little bit outside the box and some latitude to sort of regale us a little bit about his approach, and we're working together on a cool new initiative, and the PMD Alliance are working with us as well around some ways to bring some content that's a little bit different from the videos that we've been recording over this last year, and also some blogs that we've been writing, and just some really important resources, I think, as we think about COVID and how we're hopefully going to emerge out of it and move forward in life as people who care about Parkinson's, and kind of what the best way to do that is. So without further ado, welcome, Greg. Maybe tell us a little bit about your journey into landing up in Baltimore and sort of why you do the work that you do around Parkinson's. Teach us a little bit about that.
Sure. Thanks for having me, Indu. Really, for me, I think the journey, at least regarding Parkinson's, first started when I met Laura Marsh. Laura Marsh was one of the attending physicians at Hopkins, and she really had a passion for taking care of people with Parkinson's disease and doing research, clinical research on Parkinson's disease, looking for answers. And she went to Oberlin, so she had a very open mind about anything that worked and helped the Parkinson's community. And so it was really her influence that, I thought I was going to go into private practice and go down to Florida and, have a good life and, take pictures of the beach like you do. But instead, I stayed right there in Baltimore, which isn't terrible, but really found, a passion for Parkinson's disease as well. And I mean, it's a disease that really affects every aspect of life. And so I think in order to solve the problems and to better manage it, you have to have a broad sort of conception of the disease. And that's really what I want to talk about today, is a broader view of Parkinson's.
Awesome. Well, we're excited to hear from you, because I know that, like I said, we drink the same Kool-Aid. So I'm excited to see sort of your concept of it and how we can kind of, bring in the patient voice eventually and try to, sort of make a difference for patients, and working with advocacy organizations as well as part and parcel of that. So yeah. So I don't know if you have slides, or how is this going to run? You tell me.
Yeah, it's funny. I can talk without them, but I have some slides that I think will help keep me on a straight course.
Yeah. Perfect. And in the meanwhile, Greg and I have been talking a little bit about wellness today. We actually had a meeting that was earlier this morning. So in the meantime, maybe in the chat, let's just see, for our patients and caregivers out there, how are you guys, contributing to your own wellness? What are the strategies? Maybe pick one strategy and write it in the chat that contributes to your wellness that you're trying to focus on these days. You can go ahead and start. We'll sort of check in with the chat.
Okay. Let me get the screen shared here, so you guys.
We already have a couple of meditations as answers.
Okay, here's the screen. All right. So just to sort of start with the goal of the talk, really what I'd like to do, and this is why I think, I want to thank Indu again for giving me a little bit of latitude. Now, whether she is glad she did that in a while, we'll find out. But I really want to take these next 20, 30 minutes to reimagine Parkinson's disease as a mind-body disorder, okay? everybody, I mean, if you ask anyone in the lay public, what's Parkinson's disease, they're going to tell you a movement disorder. And I'm going to tell you why that's only partially true. Okay. I want to discuss how both the physical and biological aspects of Parkinson's disease might be expressed as depression and other mental conditions. Okay. And really, I think that's bridging this mind-body gap, which I think really started with Cartesian dualism. And I'll mention that at the end to see if I've actually persuaded anybody that this is really a mind-body disorder, and that managing it well requires mind-body solutions. Okay. So really, I think I like to start with a little bit of a retelling of the traditional history of Parkinson's. Okay. So this slide that I'm showing you is one of the culprits. So diseases that cause degeneration of the neurologic system are often the fault of misfolded proteins. And in the case of Parkinson's disease, it's a misfolding of alpha-synuclein. Now, alpha-synuclein has important native functions in the body. It does important things at the cellular level. Unfortunately, when you have Parkinson's disease, the alpha-synuclein starts misbehaving, and it misfolds with itself and other proteins like ubiquitin and lumps together to form the Lewy bodies that kind of define this disease. Okay. And if you look at the slide and you read it right to left, you can see the sort of aggregates of alpha-synuclein coming together to form the Lewy bodies you see in slide H. Okay. And at that point, this triggers a cascade that results in cell death. And most conspicuously, and this is the traditional slide that you're going to see when people talk about Parkinson's disease, the cell death that's most clinically apparent is the cell death that causes the pigmented neurons in the substantia nigra pars compacta to die off. So in that top part of the slide, you can see that normally pigmented substantia nigra. Now, as the cells die, you can see, you can't see that dark line anymore. And that's the loss of at least 60 to 80% of the dopamine cells in the substantia nigra. Okay. And then what you get from that is the clinical sort of presentation or traditional clinical presentation of Parkinson's disease. And remember, I'm going to tell you a different story in a few minutes, okay? Because this really isn't when the disease starts for most people, but this is when the disease is typically first recognized. So you lose 60 to 80% of these dopamine containing neurons, and you develop what we call bradykinesia, which is a slowing of physical movement. And most often you'll see this when you go into your neurologist's office, you'll tap your fingers or stomp your feet, and you'll notice a reduction in amplitude of those movements or a slowing of those movements. And so if you have that plus at least one other symptom, and that's typically that pill rolling tremor or some increased tone or rigidity in your muscles, that's really how Parkinson's even today is diagnosed. It's a clinical diagnosis, right? But that's really only part of the disease. What we now know is that in the majority of people, there are areas of the brain outside of the substantia nigra. So we use this term extranigral, okay? Areas of the brain that are affected. And these include things like what we call the raphe nuclei, which produce serotonin, and the locus ceruleus, which, by the way, in Greek means the blue place. It's also depigmented, but I'll bet you've never heard another lecture in Parkinson's that talked about the depigmentation of the blue place, right? We talk about the black substance being depigmented, but we don't talk about the blue place being depigmented. But people lose noradrenergic neurons due to Parkinson's disease. Now, the reason this is important is that the raphe nuclei and their serotonin and the locus ceruleus and their norepinephrine, that's largely important for regulating mood, okay? Now, it also affects other parts of the brain that regulate sleep. And so you're going to see a lot of symptoms in these domains as the disease progresses. And it's not even until the third stage of progression of this disease pathologically that you enter that substantia nigra and start to see the motor symptoms. So for many people who are diagnosed with Parkinson's disease, it's actually the disease process itself has actually been active in the lower parts of their brain for maybe 10 years, maybe more, okay, by the time you actually are diagnosed with the motor symptoms. So what might you see prior to the motor symptoms? Well, some of these are non-specific, but we now know are definitely linked to the same pathological process. So that maybe one of the first ones is constipation. And we actually find Lewy bodies down in the autonomic nervous system of the gut early on. But constipation is really non-specific. So the majority of people who have constipation aren't going to go on to have Parkinson's disease, but some will. And then, maybe later people start to have REM sleep behavior disorder. And this is a condition where you act out your dreams, you thrash around, and you have dream enactment because you're not paralyzed as you should be while you have the dream. Now, people who have this REM sleep behavior disorder, again, some won't go on to have Parkinson's, but the vast majority will. Maybe 80% or more of these people will go on to have Parkinson's disease. And then from there, some people with anxiety disturbances and mood disturbances like depression or bipolar disorder, they have almost a twofold increased risk of Parkinson's later in life. Now, the majority of people who have depression won't get Parkinson's, okay? But some do. And so what we're wondering is, are some of these people who have depression, is that just early Parkinson's, okay? Same thing with these other symptoms, REM sleep behavior disorders. That's just a manifestation of this pathological process. Loss of sense of smell affects up to 90% of people with Parkinson's. And so all of these things are these extranigral, non-motor symptoms of Parkinson's disease. And so when you think of Parkinson's disease, it is really much more than just a movement disorder. It affects the mind and the brain and our thought processes and our emotional regulation. Okay. And so now I want to take this sort of thought experiment just a step further. Okay. Here's a longitudinal look. If you were to reimagine Parkinson's as more than just a movement disorder, okay, that means that if you're talking just about the movement symptoms, you're literally coming in somewhere in the middle. So if you look at the horizontal line, that's what we call the x-axis, at time 0 there, okay, you see the time in years with 0 at the bottom? That literally is the middle of this graph, right? And that's when the movement symptoms start in Parkinson's disease at time 0. The problem is, for many people, 10, maybe even 20 years before that, that same alpha-synuclein disease process is going on, and they're having maybe constipation, but nobody thinks that the constipation means anything specific. And then maybe they start having REM sleep, behavior disorder. So now you're getting suspicious. Maybe they have some depression, right? Which, as I mentioned, is associated with a twofold or more increased risk of Parkinson's later. And then, as the disease progresses toward the midbrain and the substantia nigra, you lose 60, 80% of those neurons, you develop your motor symptoms. And from there, now you've got this full spectrum, mind and body, affected by Parkinson's disease, okay? And we know this to be true for not just some, but maybe the majority of people with Parkinson's disease, okay? Yet, almost all the therapy for Parkinson's traditionally has been focused on the motor symptoms alone. Okay, this is a really kind of noisy slide, but again, I just want to show you in a more granular way how the disease in some people works its way through the brain, okay, to produce these symptoms. So, maybe it enters some people in the gut or the olfactory nucleus, an exposure, who knows? And it makes its way up the brain, and you can see the brain stem there with the dorsal motor nucleus of the 10th cranial nerve. That's a nerve that innervates the GI system, including the gut and the colon, where you might be experiencing constipation. From there, it goes up to that place I talked about, the locus ceruleus, depigments those neurons, and then up into the substantia nigra. And that's when the motor symptoms start, okay? So now let me show you at the symptom level. So this is a time plot of depressive disorder onset. So people who are having their first major depressive episode, okay? And then later found to have Parkinson's. So again, the same idea. Time 0 means the time at which they're diagnosed with Parkinson's, the time at which they first notice movement symptoms, okay? Everything to the left of 0 is before they even know or have been diagnosed with Parkinson's disease. And everything to the right is after Parkinson's disease. And one thing I want you to pay attention to is that there's a peak right at time 0. So there's some of these people where depression is occurring early, and it may or may not be linked mechanistically to the Parkinson's. But certainly whatever happens at the time of diagnosis, whether it's the stress of diagnosis, the introduction of medications, there's a peak in the incidence of depression. Now, look at this. This is anxiety. And same thing. This is their first anxiety disorder onset. The one thing that's conspicuous that I hope you appreciate is that both of them have a peak right around the time of diagnosis with the movement disorder symptoms of, that's the most likely time for occurrence of both anxiety and depressive disorders. But the anxiety disorders have a longer tail to the left, meaning that anxiety disorders seem to predate the diagnosis of Parkinson's by a little longer than does the depressive disorders. And so, again, whether these are prodromal symptoms of early disease, meaning that it's the same process, or if they're just risk factors, meaning it's an open window through which the pathological substrate of Parkinson's disease is more successfully able to enter, is still unclear. But I want to tell you that these findings of depression and anxiety producing an increased risk of Parkinson's later in life have been replicated dozens of times in almost every nationality you can mention. Probably one of the most impressive is people looked at the Taiwanese National Health Registry, which really, because it's a national health registry, it follows people cradle to grave. And they found an almost twofold increased association between mood disorders and later Parkinson's in that large cohort, hundreds of thousands of people. And so, again, why are these peaks occurring? Well, people are diagnosed at time zero. They're reacting to the diagnosis and symptoms, and then dopaminergic medications are introduced. And so really, the next segment of this talk, I want to kind of persuade you that there is a clear interaction between the physical and mental, or the mind and body elements in Parkinson's disease, and that to really successfully manage and fight against these symptoms, you have to think in that holistic way, okay? Your body's not going to do what you want it to if your mind doesn't come along, and your mind's not going to be right if you don't take care of your body, okay? And these are things, importantly, and we'll talk about wellness near the end, but these are exactly what wellness is about. It's a more global look at health, okay? Instead of just focusing on when you're sick or have a problem, it's how do you proactively engender well-being, okay? So let's start with an example from depression. And this is, again, illustrating how mind and body are connected in Parkinson's disease. So right now, the largest ongoing study, and maybe one of the largest studies ever in Parkinson's, is hosted by the Parkinson Foundation. Some of you may even be participants. It's called the Parkinson's Outcome Project, or POP is the acronym we like to use. And it's really this longitudinal look at which treatments produce the best health outcomes in Parkinson's disease. And one of the early findings from this big study is that depression has almost twice the impact on quality of life as even the motor symptoms that define Parkinson's disease. So even though it's a movement disorder and that's what everybody's running around treating, it turns out that if you don't treat depression, it's probably one of the biggest drivers of worsening quality of life. Now you say, well, what's that have to do with physical, what you told me, mind, body, you're going to connect these two things. So we took a look at this. We said, okay, great, it's affecting quality of life, but how does depression affect your physical well-being? So my group published a study on the longitudinal impact of depression on disability. And so what we did is we had this longitudinal study that ultimately ended up running about 15 years. And we analyzed the first 6 or so years of this longitudinal data set. And what we found was that when we looked at people's ability to bathe, walk, speak, very physical things that everybody has to do every day, that if you were depressed, you were less capable of doing these physical things than if you were not depressed. And let me show you the graph, because I think that's probably the most impactful way to demonstrate this. So if you look at that dashed red line, okay, that's the people who are symptomatically depressed, okay? If you look at the solid green line, that's people who are never depressed. And if you look at the dashed blue line, that's people who had a depression that either remitted spontaneously or was treated into remission. Now, the visits, each visit is about 2 years apart. So we see people in person every 2 years, okay? So this spans 8 years of a participant's life. And then on the left, that NWDS score. That's the Northwestern Disability Scale. And that really is just a measurement of how well you perform hygiene activities, dress yourself, walk, speak, all as one lump sum. And the higher that score, the better you function. So 20 is poor functioning, 50 is high optimal functioning. And what you can see is that everybody with Parkinson's disease, regardless of whether they're depressed or not, declines a little bit over the 8 years, okay? But if you look, those people that dashed red line who are actively or what we call symptomatically depressed, they're functioning at a lower level, a significantly lower level than any other people who aren't depressed with Parkinson's. And here's the good news. If we treat the depression, or if the depression spontaneously remits, people jump up to that higher level of functioning. So to me, this clearly demonstrates that treating the mental disorder of depression results in better physical functioning, less physical disability. And so to me, this is one clear illustration of that mind-body connection in Parkinson's disease. And it's really important. And this was actually mentioned at the Movement Disorder Society plenary a couple of years ago. And I think hopefully what it did is put on everybody's radar that we have to really treat mood as an important symptom in Parkinson's disease to take care of. Now, anxiety, I'm going to hopefully show you a similar thing, how anxiety and movement are connected. So this mental experience of anxiety and how it affects your movement, okay? So first, I want to just give you a little more data. You know, how I kind of mentioned that anxiety disorders and depressive disorders are associated with an increased risk of Parkinson's later in life. Here's a display of the robustness of that association. So regardless of whether we measure anxiety as a disorder, which is sort of a formal medical diagnosis, or as a symptom, or even as a personality trait. So even people who just are neurotic, as we say, any type of anxiety manifestation was associated with an increase of later Parkinson's. And so that robustness tells us that it's probably attached to the biology of the disease, okay? Or the biology as a risk factor for the disease, okay? Now, when we looked at, this is sort of a recapitulation of those other figures I showed you, where time 0 on the horizontal line is the onset of Parkinson's. When we looked at anxiety, there was really a bimodal distribution of anxiety in Parkinson's. And by that, I mean, there was certainly a bunch of people who had anxiety earlier in life before they were diagnosed with Parkinson's. And that anxiety was things like generalized anxiety or panic disorder, and it may or may not have been associated with the disease. But at time 0, that sort of orangish peak, what we noticed is those people often had an anxiety that was associated with on and off fluctuations of their dopamine medications they were using to treat their Parkinson's. And so this was clearly not just the disease and not just some idiosyncratic anxiety. It was this interaction between the dopamine they were taking for Parkinson's and anxiety when it wore off, okay? And so basically, when we take dopamine medication for our Parkinson's symptoms, we call it the on state when the symptoms get better, and then we call it the off state when the symptoms return after the medication wears off. Now, if you have a good neurologist, what happens is they give you a dose, and then they give you a second dose, and they keep them close enough together where you never experience that wearing off. But as the disease progresses, even the best neurologist can't keep up because the disease makes the process too brittle, and you often have this on-off fluctuation. And that's really what this little table shows. Is you take the dopamine, you know, your Cinemet, your symptoms get better, you move a little more fluidly, but then it's time for the next dose and you might start to feel a little slowed down, or some people even feel dysphoric or anxious. And so we thought, this is important, and maybe this is an important connection and reason for anxiety in some people. And so fortunately, a group out in Oregon, and I saw some participants today are from Oregon, so they'll appreciate this. You guys have one of the best Parkinson's group in the United States out there in the Oregon health system. So Jay Nutt, who he might be emeritus now, but Dr. Miracle and Jay Nutt Dr. Nutt did a a study where they infused dopamine into people with Parkinson's disease while they were tapping their finger, and they measured their mood. And so what they found is, as they infused the dopamine, their mood got better. Okay, so their mind, their mental state got better, and they tapped faster. And when they stopped infusing the dopamine, both their tapping, their movement speed decreased, and so did their mood. They became, maybe even a little dysphoric or depressed. And so, again, this demonstrates a connection, but I want to show you that it also pertains to anxiety. Now, unfortunately, they didn't map it with the movement or tapping, but they found as they infused dopamine and measured anxiety, anxiety went down, it improved. And as they stopped the infusion, it went back up. So clearly, here's this connection between the mental state of anxiety and this infusion of this biological compound, levodopa, which is one of the precursors of dopamine. And so clearly this established this link. And then my group was actually funded to study this in real, in a huge group of 200 people with Parkinson's on and off their medications. And we actually hope to publish that in the next month or two, depending on how quickly it gets accepted. We'll see. But this all sort of, I hope I've convinced you that there really is a substantial mind-body connection in Parkinson's, and that you have to work on these things together. You can't leave the mind in one box and the body in another, okay? And that's where I want to really segue to wellness and mental health in Parkinson's. And the first thing we have to decide, and we're Indu and I are actually working on this with a group, and we need patient input too, right? Because we can't just tell you what wellness is. You guys have to help us know what wellness is. So the World Health Organization, though, defines health as a state of optimal well-being, not merely the absence of disease and infirmity, okay? So then wellness is maybe the active pursuit of activities and lifestyles that lead to a state of health. Okay. So I always like to say wellness is a verb. Okay. Wellness is something you pursue, sort of like enlightenment, right? You're always chasing it. And so traditionally, we define health as the absence of illness. Well, in wellness, that's only half of this picture, right? Illness is only the left side. Wellness is getting all the way to the right side, right? And that's where we all want to be, whether we have Parkinson's or not. And so, I think being aware, accepting what you have, working on growing as an individual, this is even beyond the symptoms and defeating the symptoms or managing the disease. This is something we want to sort of teach people to do better, okay? And in Parkinson's, that might be unique in terms of some of the elements, in terms of what you need to do. And at the end of the day, what I hope discussions like this will facilitate is the end of this mind-body dualism. So, Rene Descartes was a philosopher, and he sort of had this opinion that the mind and body were separate. And I think he meant well, but ultimately what it ended up doing is it made psychiatry the redheaded stepchild of medicine. Because, all my neurology colleagues, I said, well, geez, if you guys are studying the brain, what am I doing? What does that leave for me? And today we know that the mind and body function interdependently, okay? And I think, look, if you have a friend with diabetes, you talk about it at the dinner table, right? Nobody's embarrassed. Hey, I got diabetes, I take metformin, right? But boy, if you have a mental illness, if you're depressed or if you're hallucinating, there's a lot of stigma, right? It's embarrassing, and it shouldn't be that way, because the mind and body are the same. And if you nurture them both, you can better manage and solve these problems. And there should be no reason, in my opinion, to have any stigma toward this. But I think this is going to take some work and some undoing. And, frankly, I think Parkinson's disease is a great forum for this, because it's truly a disease state where you can see a concrete connection between the mind and body. Okay. And I think with that, I'll sort of turn it over to Indu to let you guys ask some questions about what I just told you.
That was awesome, Greg. Great way to start the discussion. And I think, so much of, I think with the pandemic, sort of coming out of this pandemic, I think I've sort of sensed that there's, a shift in people's energy, and people are a little bit more open to sort of the effects of, the mind and its effects on the body. I think we, even as healthcare providers, and a lot of us have just been trying to support each other and realizing that we're exhausted and that the fatigue of COVID and just, bad news and, everything affects our body and we, aren't sleeping well. And we're realizing that that makes us feel bad. And so I think this sort of timing is kind of really crucial in some ways, and is kind of interesting, for us to sort of start having these discussions. Maybe just as a question, I know you're treating a lot of patients and even on the inpatient ward and stuff like that. What kind of effects are you seeing just from the pandemic itself? And sort of what are you worried about from our emerging from it, and moving forward as a population of folks that care about Parkinson's patients?
Yeah, probably the most profound thing I'm noticing is I think as a health system globally, we've underestimated the impact of social isolation and loneliness. And I know there's an emerging awareness, but I can tell you that what I've witnessed in almost slow motion over the past year and a half that we've been under quarantine as a nation is that as people become more and more isolated, it has just a profound effect on them mentally and physically. So mentally, without the connections, I see people lose confidence in their ability. I see them become a little mentally unfocused, myself included. I mean, geez, what's the difference between Thursday and Tuesday if you don't have your normal routine? And I think, especially in retirees, they might be even a little more vulnerable to that. And then in terms of the physical, just a little bit of running around that we did, whether it was physically going to appointments, I'm seeing a lot more physical deconditioning.
Yeah. And so what are you sort of like, because I know that it's hard to access even patients, and it's been sort of one of those things in the pandemic where I think a lot of us have had sort of the telehealth appointments with the patient sort of there, and you're trying not to start medications on people, but might see them decline. What kind of interventions have you been actually able to do that you felt comfortable doing sort of in that sort of, mindset?
Yeah, I will say that I hope that what we've experimented with here with telehealth um, will emerge as an option, because I know that a lot of my patients, even though most of us still like that in-person feel, I mean, I do too, but I like this as an option for people who might have motility issues. I think it is a little harder to, and maybe it's just because we haven't had enough practice to convey the same warmth or attachment. But I think the social connection is nourishing. And I mean, we don't necessarily have a objective way to quantify it, but in the parlance of psychology, we use the term stroke. I don't know if you've heard this term, but
I don't think so.
when you're in conversation with someone or having any sort of interaction that that communicates information, when there's an emotional element to the transaction, we call that a stroke. And so, most people say that you need a certain number of strokes emotionally to be nourished. And I know everybody says, oh, that sounds like soft science or whatnot, but we're a social animal. I mean, you can go all the way back to the blow bee, wire mother experiments. And if people aren't socially nourished, they're emotionally more fragile and less resilient. And I think that's what I meant by under recognition of the impact of social isolation here. It's, look, if we don't walk, if we don't do things physically, our body physically becomes deconditioned. If we don't interact with others, we become socially and emotionally deconditioned. And I think that's been incredibly underestimated. And so the one thing you asked, what do I do besides pills and pushing pills, is, boy, just encouraging people to remain socially connected, whether that's via Zoom or other sort of, telephone or video type interactions. You need to find a way to be socially and emotionally nourished.
Yeah, people are asking, does Zoom video calls count, or even this telephone, does that count?
Absolutely. I have to tell you, there is a learning curve. I will tell you that, and this will maybe sound silly, but I can tell you, I think it's true. My ability to convey my message and just function on Zoom has increased in leaps and bounds because of how often we do it in the pandemic. I mean, there is some Zoom fatigue on the downside of it, but what I would tell people is just start getting comfortable with it, because, whether you're be your distant relatives or your proximal relatives, this interaction, you'll find, can be facilitated by Zoom. And, I told people, make a list of people you haven't talked to in 10 years and reach out. I mean, it's not like we're doing anything in the middle of this pandemic.
Yeah, I mean, that's been my message, but it's been a little odd coming from a neurologist in the middle of a pandemic who specializes in Parkinson's, but I've become the loneliness queen, I guess, of the VA and stuff. But I think it is hugely important. I think we're really realizing how social connection has been missed. And I think it's an opportunity for us to really realign, that, as well as the rest of sort of the, the sort of nurturing, I guess, family or tribe or whatever. Some of what we've talked about, Greg, has been around rethinking sort of who might be your allies or well-wishers. I think I think we've talked about the fact that, the model where you wait until motor symptoms to get diagnosed with Parkinson's, you go see the neurologist, me in my white coat, in an office where you have to navigate the parking and the traffic and, all this stuff in an urban environment just to come to a center of excellence where I practice, in a very crazy part of Los Angeles, and then be diagnosed by me. And then I send you off and we counsel you here, in the VA or whatever. And I spend extra time doing that. But most times, it's a 20-minute, 30-minute interaction then for follow-ups. And you have, once in 6 months, you check in. And so, if that's the only real information that people get, and then maybe once we see you for a while and something has gone awry, then I introduce them to you, right? As a geriatric psychiatrist who, is then fixing things in a time of crisis. And so I think that model has been, I think, not a good one. And I think we are able to possibly relook at this. And so what are some strategies? I think you've been looking at, maybe support group, mentoring, buddy systems. Maybe teach us a little bit about just maybe speak to that old traditional model, because I think, you have some opinions, I know, and then maybe some out of the box sort of ideas that you have just to really sort of help with the wellness and mind-body support, and who could be involved in that.
Yeah, absolutely. So I think, one of the points you make is that we don't really have any proactive mental health strategies, right? If you talk to your medical doctor, right, they're going to tell you, hey, eat a Mediterranean diet, get 150 minutes of exercise, keep your cholesterol low, right? Don't eat too much sugar. And all of this will prevent a variety of medical conditions, right? And that's proactive, and that's something you control. But if you go to a psychiatrist or someone who provides mental health care, what are the proactive strategies to keep yourself well, right? To prevent illness or decrease the risk of illness. And I just sort of made an argument that Parkinson's disease is a neurological disease that sets you up, that increases your risk for things like depression and anxiety and all sorts of mental health issues. So I agree. I mean, I think our current model of waiting for there to be a problem, especially when we know those problems occur at an increased rate in Parkinson's, is not a wise model to continue to follow. And here's part of the problem. And I want to give you something that's fortunately changing. So I'll talk about it because I like to be optimistic. Our healthcare model, at least the way it's reimbursed, is very much a reactive model here in the United States, okay? And I'm sure other places, but let me give you an example. So you break your hip, okay? And you should have very little problem getting reimbursed for acute physical therapy to rehabilitate that hip, right? But it's a time-limited course, and it's only triggered after you break your hip, right? And then it stops as soon as they think you're at or near baseline, right? And not showing progress. Well, in Parkinson's, you're a fall risk after a certain stage of the disease. Initiating physical therapy to decrease that risk used to be a real pain because it was a chronic condition. So there was no acute, billable necessarily code unless they fell. So then again, you're reacting to a fall, like you've already had the harm. And so in that same way, I think, we need to think, look, we know statistically that these depression, anxiety, and other mental health issues are going to happen. What are we prescribing early to keep people healthy. And this gets back to the idea of nourishing the mind and the body to keep the person healthy. And so let me give you some examples that are a little outside of what's currently reimbursable or on the menus of our health systems. Now, I do want to say that CMS, the national system here, is becoming increasingly aware. In fact, they have social determinants of health sort of now recognized, but I just think it's not happening as fast as the rest of us would like. So if you look at loneliness and social isolation, they've now shown that those increase the risk of cardiovascular adverse outcomes, heart attack, stroke, as much as obesity and high blood pressure. So this mental state of being isolated and lonely is as risky as high blood pressure, diabetes, and obesity, which is amazing, right? And again, makes that mind-body bridge. So what we're thinking is that we can rely on the Parkinson's community, whether it's formal support groups organized by foundations or grassroots, just, hey, we all got together online, in a chat room or whatnot, where we're supporting each other, we're socially connected, and, we're conveying a positive message. Okay. And that's sometimes been called social prescribing when it's done in a directed way, whether directed from the individuals with the disorder or disease or from the healthcare providers or the community itself. And I think that's one of the things that we really want to start to promote is this social prescribing, and then matching people so that peers who are successfully navigating the disease experience can help, people who are either struggling or new to the disease take a faster route to wellness.
Yeah, it makes so much sense, right? But it's sort of been hard. But I think we can break down some barriers a little bit with just, Zoom. I agree. I think it's sort of, at first everyone gets a little freaked out. And I know when I was starting to see my patients, there was a learning curve. But, I think there's, once you kind of get past the sort of whatever, I mean, I think honestly, Greg, you and I connected around Christmas time on Zoom for the first time. And I feel like I already know you really well. And so it's been kind of transformational. So, well, I think this has really been resonating in the chat. And I just wanted to sort of spend a minute just sort of focusing on a little bit. So there's been some comments here about the PMD Alliance programs, along with support community does wonders for people. Somebody mentioned Vivek Murthy, the former Surgeon General, writing a lot about this issue. And this was actually pre-pandemic that he did that work. And now I think he's focused on like COVID relief and stuff. So he's spending a little bit more time, but he's actually the current former, he was the former and now I used to have to say former Surgeon General in the time of the previous administration, but he's now the Surgeon General again. So hopefully we'll continue to see some work in that, but I couldn't agree with you more. As you know, it's like I paid you to say this. So you're like my plant, but I think a lot of this is really Dr. Pontone for next Surgeon General. Apparently you might be on here. This is the best audience ever. It's kind of hilarious. People appreciate your brilliant big picture view of health and disease continuum. People have been writing a lot in the chat. Everyone read about that to each other. And people have been saying that that seeing the faces here and connecting on Zoom with the PMD gang has been great. And I think this is one idea, right? So it may not be for everyone, and sometimes in person isn't for everyone. I think sometimes on these online, to be able to keep your camera off if you're not ready to really seek people out, but you can be part of a conversation and kind of lurk in the distance or whatever on the sidelines, it still connects you. So I think, again, sort of put out your feelers. And I think, I know in the yoga world, we're feeling like somebody who may not walk into a yoga studio and take a class, they may be more apt to do some of this stuff online. So I think that's pretty exciting. People have been talking about all kinds of things that they've been doing at home, and excited about your idea of the sort of strokes. And I think we should think a little bit more about what would count for that, because I think people have really been unclear. They feel like it's such a monumental thing to have to take that step to like go to an in-person support group or sign up like in advance for a class or pay $20 or whatever. And then they feel like they have to pour their whole heart out to everyone and they don't want to really share, right? But I think that what I've noticed, at least in the literature, is that even standing in line at, let's say the Trader Joe's or whatever, when you're waiting to get in and just sort of waving to the person in front of you and saying, how are you? That counts, right? As a stroke. So what kind of things, maybe as I'm going through the chat, other subtle things that people may not realize maybe count as strokes that kind of count towards some global sort of, ideas of socializing that may be a little more informal.
Yeah, no, I mean, I think you gave a great example. It can be as small as just an acknowledgement through a wave or a head nod, you know, when you see someone in the community. It can be more substantive, you know, it can be, you know, committing to showing up for a group or community activity, you know, where you're actually then participating in a shared activity. And I tell people that, I'll give an example of probably one of the easiest, and even if you're the most shy person on your block, if you walk, which all of us should be doing some exercise, if you walk around your block, for instance, and your neighbors are out, just literally saying hi, and then maybe the first time all you do is wave or nod your head, and then eventually there's some casual conversation. And this is, like I said, I think people have really underestimated the importance of these small gestures in terms of their importance to our well-being. And now that we're isolated, I mean, people, you know, they're locked in and they, you know, they don't go out, and they know something's wrong, but they can't put their finger on what's gone wrong. And I think for many people, these small gestures of connection are the missing element.
Yeah. And somebody said having a little chat with the cashier, actually, which is true. So absolutely. The good news about Zoom in some ways is that you don't have the mask on. I feel like for me, wearing a mask, my eyes are very expressive. People always think I'm like not happy or something, but
well, you know,
one of my patients,
I have a bunch of great patients who use their sense of humor on me. You know, we were complaining about the mask and they said, well, now you know how we feel.
That's probably true. Tracy says that they're doing companion calls as a check-in for our community members. So I think, you know, the phone call idea, and I love the idea of listing 10 people on your list. I think sometimes when you write it down and, you know, I think that it's been, you know, sort of resonating with each other that, you know, things like, so we asked about the wellness strategies on the earlier. People are doing meditation, journaling, music, exercise, gardening, yoga, doing kickboxing and things like that. Video gaming, that's a new one. Is that wellness? Because my children are very well then. I'm a little scared of that one, actually. I'm not too sure. An artist, you know, who's doing that, gratitude journaling, prayer, meditation. Prayer is a good one, actually, that we forget a lot about. In some communities, that's a huge source of wellness. Cycling. So there's been some questions specifically about Lewy body. I don't know that we can address those in this talk because I think this is sort of a little bit of a different one, but maybe we can. Greg is an expert in many, many things, but we might sort of save those because I think that's a whole talk in and of itself. And then somebody asked about the role for palliative care, which maybe we can just sort of drizzle in, because I know as a geriatrician, you probably have some of this. Tai Chi is something else that people have talked about. Using drive-bys. I don't, what does that mean? Like people
are they from LA? Be careful.
So I think maybe the thought would be like to stand on your porch and then people wave at each other. And I know that there's been drive-by birthdays. So, so anyway, but there's been some interesting things. So yeah, board games, playing cards, puzzles, things like that in your house. So yeah, I mean, whatever strategies work for you, but I think, sorry, I think that we were just talking about something and I interrupted you, Greg, but yeah, maybe talking about the palliative care piece.
Oh yeah, palliative care. So, well, first of all, I think, and this is true, I think in general, palliative care has been unfortunately conflated with end of life. And it doesn't necessarily have to be end of life. It's probably more appropriately defined as alleviating suffering and increasing quality of life. And I think that's the first thing, is a lot of the people who are in palliative care right now are trying to sort of rebrand it, okay, so that it moves away from just, you know, the end of life type issue. And so it's about living at the highest quality that you can obtain at the time, regardless of where you are in a disease, you know, or in life. And I think, you know, the paradigm is a little different with palliative care is the other thing. So most of the time when you go see a doctor or you enter traditional medical care, it's about curing something or resolving some symptom. Whereas palliative care is more about alleviating suffering and increasing comfort and quality of life. And so I think if we can start to, again, reimagine palliative care in a more positive light, that would maybe first open the door for more people to be open-minded and considerate. But it definitely, for many people with Parkinson's, I think it's a resource that is really underutilized.
Yeah. So I think people know that my passions have really been around the integrative medicine world, so the wellness stuff and things. But then I've also actually been really interested in palliative care. And one of the things that I think is really interesting to me about the way that they discuss things is really not just the absence of disease, right? So it's really about living in that World Health Organization definition. So it's really about this sort of more holistic, sort of full, like a really true mental, spiritual, and physical well-being, sort of really promoting those things and thinking about the person in sort of their environment and the space of all the things and all the people that mean things to them. And it's at that stage, and I think also when we have mental health crises, that we start to reimagine sorts of these, approaches to health, right? And so I would love to see, because I think that, certainly in a disease like Parkinson's, you have stages of needing more help. And then, other stages where you're coasting along. So you sort of have, and sometimes it's a diagnosis, as you showed, actually. I was really fascinated by that picture of the anxiety and depression and sort of that peaking at the time of diagnosis. And so maybe, some of the chats that we had a physician who's an ER doc come on and talk about when he got diagnosed and sort of what he would want to sort of realign. So I think maybe, sort of supporting people at diagnosis a little bit more with certain things. And then, as they're going through, maybe some transition points where we sort of have a team kind of come out and be able to support, and then go back into sort of the woodwork a little bit as people are doing well, but sort of not waiting until sort of these crisis points where it's already too hard to intervene. And I think we can learn from these strategies of, like, sort of the more holistic views, more sort of thinking about that quality of life thing. It's not just removing this disease state, right, or fighting a disease. It's really sort of from diagnosis, and thinking about diagnosis not just as the motor time, right? Like, this is not the first day you had Parkinson's, really thinking, hey, well, maybe I've actually been having these issues sort of, along the way. And so sort of thinking about how to drizzle in these wellness strategies, honestly, because I think that as we've talked about with physical therapy, for example, in the model it's reacting to a hip fracture, right? And that's almost too late in the game. If you're reacting to a crisis in mental health, it's almost too late in the game. But, if we think about the time of diagnosis, and you showed beautifully the sort of trajectory that leads up. So day zero of diagnosis is actually, years into the pathology. Maybe that is actually going to convince somebody insurance wise or somebody else, or we have to sort of align this to think about that day zero as the time when we start the wellness talks, and we sort of start hey, you may need some more support. Who's going to be in your support system? Maybe get a friend, a Parkinson's buddy, a mentor, whatever, some different alignment of folks that may be able to support, through the later trajectory, right? So I think a lot of sort of cool things. So drive-by shootings for dementia care partners is taking a car ride to see a friend and shooting a picture from the car while maintaining COVID distance. Okay, I'm learning all kinds of things about what our patients are doing. And then, yes, lots more strategies, but people are really loving our talk here and sort of rethinking about this a little bit. So I think this has really been inspirational, from a rethinking perspective. Greg, I'm just going to give you somebody writes here, virtually all primary care doctors and most general neurologists give the wrong message at diagnosis, focusing on the progression and symptoms and all the downside. People need to know their good quality of life is possible with PD on their very first visit. That actually, Paul, who wrote that, is what I was going to actually ask you is, so if you could tell our gang of 100 something plus people out there and whoever will watch this, as a geriatric psychiatrist, so about aging well and mental health, right? Because you've done 2 years of fellowship training and you see all of the things, right? So you've seen sort of the end stages of things and different parts along the way. What are your secrets to success? What is the secret sort of sauce, Greg, from your perspective? You have, I think, about 4 minutes or 3 minutes, something like that. And I'll hand it back to Andre. And I have to actually hop off for presenting my own grand round. So can't go over time, even though this is like a fascinating talk and we might have to have you back. But yeah, give us your secrets.
Yeah, well, so, I really do. I think it's having a sort of holistic, global approach to life. And then I think once you've achieved that balance, you're going to better handle whatever's thrown at you. And so, I would encourage people with or without Parkinson's to really work on themselves, both mentally and physically, in an integrated way. And I think this is really the secret to wellness, because I've seen people get the same diagnosis, have the same severity of symptoms, and have two completely different trajectories based on their attitude and outlook. And, what I don't know exactly what the secret is to the ones who do it well, but I'll bet if we put the ones who know how to do it well in the rooms with the ones who are still learning, they're going to pull them closer to the right path. And I think that's probably the secret. But again, that's about community. And so I think really, even if you consider yourself somewhat of a loner, be open to the idea of community. And I think that's also being open to the idea of being healthy, because together you're way stronger than you are as a lone wolf.
I think it is. I think we've forgotten so much about, how we're connected to the world. And we are, like, so much of what I've been talking about literally is just realizing that we are human, and human connection is like food and water. It's very basic as a need. So I agree. I think we can, redesign things a little bit, engaging our patients, engaging their caregivers, who are hugely important in this conversation. You guys know day to day what makes your loved ones thrive, right? And your thriving as caregivers also is going to help us to take care of our patients. And then engaging people like the PMD Alliance, who are, huge stakeholders in this. Andrea and Sarah and, all of her team, Rebecca, they didn't go into this because they're trying to make a buck, right? Like they care about our patients, and they really want to make a difference. So I think, we really need to, think about this in a different way. And I'm excited to partner with you, Greg, on this project that we've been doing. And we'll stay tuned for more offerings, especially in this sort of mental health wellness space, which I think is so needed. Thank you for making the time. And I really appreciate you in many ways, actually, being a partner in sort of our explorations. And we'll look forward to many more great talks. So I'm going to hand it back for our goodbye wave. And I'm going to say goodbye because I have to hop off for our grand rounds. But thanks, Greg, for joining. Really appreciate it.
Absolutely. Thanks for having
me. Happy weekend, everyone. Take care.
So now that we know how important this is actually a stroke, so we always end with a goodbye wave, and you have taught us why that is important. So I invite everyone, if you switch it over to gallery view, you can see all of the smiling faces. If your camera hasn't been off, I invite you to turn it on. And I just love to scroll through and see everyone waving and smiling and the thumbs up. Hi, Dave. Hi, Harshad. Hi, Denise. Thank you, Dr. Pontone, for teaching us and connecting us with this information. And thank you to all of you for your great questions and comments. This has been a lovely hour.
Thank you.
All right. Bye now, everyone.